Bonjour tout le monde. Good morning, everyone. Good morning, ESE. Welcome to our live studio. We're going to be sending the whole day today, and I hope you're going to join us here at the Congress Hall, but as well online for you who cannot attend the conference. I hope that everyone enjoyed the ride on the river yesterday. I did enjoy it a lot. But now to the main point. Today, I have a pleasure to conduct the interview with Professor Lara Friedlander. She traveled to us all the way from New Zealand when she works as an associate professor at University of Ontario. Her main area of research are pulp biology and systemic disease, clinical endodontics, and education. Not only is she a fantastic teacher in undergrad and graduate education with multiple awards, but she also is a very productive researcher, and she has been invited in multiple locations internationally to present her research. Lara, thank you very much for accepting this invitation. It's great to have you here.
Thanks, Monica. It's an absolute pleasure to join ESE this year and be invited to share my knowledge with so many.
Yes, so let's get started. Lara, the title of your session is very striking. Could you start by explaining why diabetes is such an important systemic condition for us to consider in endodontics?
Well, I think we need to really face the reality that diabetes is increasing exponentially globally. And whilst there is a range of presentations across the globe, it's something that we need to be cognizant of as we've got such an aging population. So, 1 in 4 of those over 75 will present to your practices with diabetes, but we've got a growing younger group too. So, they all carry those comorbidities for life. So, they'll all present to dentists.
I see. What do we know today about how diabetes affects pulpal and periapical healing?
Well, I think we're beginning to form a picture. There's still an awful lot of work to do, but we know that the pulps in these patients, they're less cellular, they've got fewer blood vessels, and the blood vessels they've got tend to be much thicker, much stiffer, and damage to the smaller blood vessels. So there's less oxygen, less nutrients, and lots more collagen and fibrous tissue. So we can expect that healing is somewhat impaired in these patients. There's a much higher inflammatory load. So if we're thinking about vital pulp treatment, maybe we need to be a little more aggressive. We don't know, but in terms of periapical disease, there really is some connection that is being declared, and much slower healing. So yeah, it really is a new force.
Okay. Are diabetic patients at higher risk of persistent apical periodontitis or root canal treatment failure? And if so, what mechanism explain that?
Look, I think it very much depends on the glycemic control, and the glycemic control through HbA1c levels is really at the heart of what the outcome for these patients is going to be. Those that have a good glycemic control are more likely to heal like a patient without the disease, but we know that patients with diabetes, their healing is delayed. There is a higher risk of persistent apical periodontitis, particularly those who have had the disease for a long time, or they may have some associated periodontal disease, which puts them at higher risk. Um, Higher likelihood of extraction in the longer term, but we don't know if these teeth are being extracted because of periapical disease, or maybe it's actually delayed healing.
Okay, I see. And from the clinical standpoint, how we endodontists should plan the treatment when it comes to these patients with poorly controlled diabetes? I'm thinking about one visit versus two
Yeah,
visits and even follow up.
yeah, sure. So I think the most important thing is to be collecting really good histories from these patients and to be working with our medical colleagues. We want to appreciate that what we do in endodontics also has a bearing on the level of their systemic disease. I think having frank conversations with patients around expectations and understanding of delayed healing. Part of the reason for this is that these patients have a much higher bacterial load, and they tend to be those nasty bugs that we would generally find at the apical area of root canals. So, much more resistant to treatment and with a much higher endotoxin level. So, greater chance of bone resorption. And because of this, I think we do need to focus more on a multi visit approach. These patients don't feel pain traditionally as much as those without disease. So, when it comes to doing our assessments at the time of filling, how accurate really are those subjective responses?
And you mentioned that communication with the patient is very important. From your own experience, do you think it's hard to make a connection with the patient, especially the one that are in the situation that the diabetes is not very well controlled because of the many reasons? Is it sensitive conversation?
Yes, they are sensitive conversations, but often sometimes it's the reality check that patients need
Yes,
to actually focus on their glycemic control. They're the only people that can make a difference.
yes.
As medicos, they can have therapeutic processes put in place, but unless they can control their lifestyle factors, it can become really difficult. And sometimes it's just the impetus to get them the help they need.
Yeah.
But it's also really important, I think, to lay out your treatment options and think more holistically. What is the strategic value of this tooth in the mouth? What else is going on, particularly from an occlusal factor? So, thinking more broadly and holistically for these patients is really important.
I can imagine it's very important to cooperate with the medical team with such patients and maybe have this
Yeah.
communication between dentist patient and the medical doctor,
Yeah.
right?
Yeah, and I think that is actually something that our medical colleagues really appreciate. Sometimes as dentists, it can be slightly uncomfortable to reach out to a medico, but actually they will say, I don't know anything about dentistry.
Yes.
And they really appreciate us making the first line. And so it really is this collaborative care and thinking from an endodontic medicine perspective.
Yes. When let's look at some questions about research. As you are conducting a lot of research, I wonder if there are some current challenges in generating strong evidence. Do we need more long-term studies, or are we missing mechanics insight from laboratory work?
Yes, I think, we've still got a whole lot to unravel in the space of diabetes. We mustn't underpower the importance of basic research and laboratory studies because what those studies do is give us information about the molecular responses underlying the disease. We can take a whole lot of radiographs, but they don't answer the why. So really important to keep going with that biological research. But the challenge we have is that we don't currently have standardized protocols. So, when we develop these in vitro models for diabetes, researchers around the world are using a vast array of glucose concentrations, time frames, different tests, looking at different inflammatory markers. And so it can be really tricky to try and compare studies. In terms of our clinical studies, once again, these patients, they present with a vast array of comorbidities, glycemic indices, and so it is incredibly hard to work out how to compare study to study when inclusion criteria can be quite different between these studies. And most of the studies out there are cross sectional, and so whilst they can provide us really valuable information about the association between diabetes and endodontics,
Yes.
they're not giving us the key information we need about cause.
Yes.
And so to do that, we really need some long term prospective studies.
Yeah, I can imagine many of these patients, especially elderly patients, they have so many
Yeah,
other diseases
yeah,
at the same time, so it's
yeah,
hard to.
yeah. I think patient recruitment is really difficult in this area of work, but at the same time incredibly satisfying. And my experience is that these patients, they are just so grateful to be invited to be involved.
Yeah. When we are looking forward ahead of us, and how do you see on the relationship between systemic health and endodontics evolving? Could we imagine a future where endodontic assessment also contributes to identifying systemic risk factors like diabetes?
Yeah, and I think we've already got really simple things that we can be doing at chairside. We know that these patients have an increased calcification, um, and we can already see, albeit crudely, pulp stones on these patients compared to those that don't have the disease. So, maybe just our plain bite wing radiograph becomes a really early biomarker for delving a bit deeper, thinking about, has this patient got a change in their oral health status? Is their periodontal disease been exacerbated? Have they got an increased active caries problem that we haven't previously picked up? These are really simple things that we can be thinking about, but as we move forward and with the development of biomarkers that can most accurately demonstrate to us the level of information within that pulp, I think that'll be really the key to us moving forward with systemic disease.
So, finally, if you could leave our audience with some unvarnished truth, no sugarcoating, please, about endodontics and diabetes, what would that be?
I think we are at a really exciting time. I think we do need to acknowledge that there is an association with diabetes and endodontics. But we're also at a point where we're seeing patients regularly. We have the ability as clinicians to be empowering these patients to take control of their glycemia. Because really it is that glycemia that is at the center of the outcomes for these patients. And also the difficulty, I think, in terms of our treatment planning.
Yes.
Yeah.
Well, thank you, Lara, for your time. It was really nice to talk to you, and I'm very glad for this opportunity. For you who are watching, thank you for watching, and please stay tuned. Next interview at 12:45. I'm going to be talking to three experts on instrumentation. See you then.